Gastric adenocarcinoma is the most important long answer question for university exam. Most common malignancy of the stomach, most common in male, and risk factors are environmental risk factor like H. pylori infection and Epstein-Barr virus infection, and that is also play important role in gastric adenocarcinoma as a risk factor like nitrate rich diet and smoked food, excess salt, and deficiency of the fresh fruit and veggies, and vitamin A and C deficiency, low socioeconomic status, and low fat and protein diet are the risk factors. And other risk factors are host factor, mainly chronic gastritis, atrophic type, pernicious anemia, hypochlorhydria, hyperchlorhydria, favor for H. pylori colonization, and intestinal metaplasia, and partial gastrectomy, and Barrett esophagus. And like genetic factors like A blood group, and family history, and family gastric carcinoma syndrome. Move on the pathogenesis of gastric carcinoma. Helicobacteria pylori increases the risk of gastric carcinoma by 5 to 6 fold. Then Helicobacter pylori infection, and chronic inflammation of gastric mucosa, then atrophic gastritis changes, then hypochlorhydria. Hyperchlorhydria favor the bacterial growth and cause chronic inflammation, mucosal atrophy, and then intestinal metaplasia, and then after dysplasia and changes into carcinoma stomach. And then pathogenesis, the familial and sporadic type. In familial,
9 loss of certain mutation in tumor suppressor gene CDH1 encode for the cell adhesion protein E-cadherin.
sporadic diffuse and sporadic intestinal type. Sporadic diffuse gastric cancer is due to loss of E-cadherin and loss of function mutation in tumor suppressor gene CDH1, hypermethylation and silencing of CDH1 promoter, which cause decrease in E-cadherin expression, BRCA2 mutation. And sporadic intestinal type of gastric cancer, loss of function mutation, of adenomatous polyposis coli, and a gain of function mutation in gene coding beta caterin, which increases signaling via VNT pathway, and mutation in TP53, and loss of function mutation in apoptotic regulator, mainly BAX, and cell cycle control genes CDK and 2A. Third, about the morphology, the most common site pylorus or antrum 50 to 60%, and in cardiac region 25%, and body and fundus 15 to 25%. Lesser curvature more involved, most common antropyloric region. Early gastric carcinoma. Invasive carcinoma limited to the mucosa and submucosa, with or without perigastric metastasis. Early gastric carcinoma has better prognosis. Advanced gastric carcinoma. Carcinoma extends below the submucosa into the muscularis wall and has a poor prognosis. Next type of classification, bone marrow classification. Type 1, polypoid. A polyp separate and fungating and ulcerated and infiltrative type. Other classification based on the microscopic growth pattern. Type 1, exophytic, polypoid and fungating type. And type 2, type A, elevated, flat and depressed. Another type is excavated, hollow, deep, erosive, crater in small stomach wall. It is closely resembled with the peptic ulcer, and the best rag necrotic in chronic peptic ulcer, punch out margin clearly seen. Another type of classification, Laurent classification, based on the histological subtype, will be divided into two parts: intestinal type and diffuse type. In intestinal type, generally see the grass morphology, a polypoid, bulky, ulcerated, most common on the antrum and lesser curvature, preceded by the previous lesion and caused by the Halitopyrglicteri gastritis. And diffuse type infiltrate deeply without obvious mass lesion, involve the broad region, entire stomach, local rigidity of the wall, desmoplastic reaction commonly seen, flattened of the rugal fold, widespread thickening of the entire wall, stomach involved non-distended, leather bottle appearance, linitis plastica. The microscopy of the intestinal type, the cohesive T cell forming gland like a tubular structure probably arise in the area of the intestinal metaplasia. T cells show apical, mucinous, and vacuole type mucin in glandular lumen. Cohesive T cell E. cadherin loss which do not form gland. T cell contain abundant mucin, expand cytoplasm with the push nucleus to the periphery, signet ring cell commonly seen. Let's talk about the spread. Spread of the carcinoma of stomach with three parts. Local spread into muscularis serosa of the stomach can invade into duodenum, pancreas, and liver and colon. Lymphatic spread to the virtue node. First clinical feature, torsional sign, and to the peri-umbilical lymph node from the subcutaneous nodule, sister Johnson nodule, to the ovule Krukenbrand tumor in blood via portal, vein, liver, and other side bone, lungs. Clinical features. In clinical vision, high risk area intestinal type gastric carcinoma may be arising from the precursor lesion, flattened dysplasia, and adenoma. Advanced carcinoma, early satiety, bloating, distension, and vomiting. Frequent bleeding, iron deficiency anemia, and pulmonary gastric outlet obstruction. Torsional syndrome from the left supraclavicular lymph node, virtue node, and torsion signed non-METs effect seen in the form of migration, thrombophlebitis, and DVT. Last, about the prognosis, depend upon the depth of the invasion and extent of the nodule and distal metastasis.